Tumor lysis syndrome tends to be one of the adverse events that are of the highest clinical significance to patients who are receiving venetoclax-based therapy. Right now, we risk stratify patients as low, medium, and high risk based on their absolute lymphocyte count, and the bulk of their disease is estimated by lymph node size and spleen size based on CT imaging prior to the start of venetoclax. Those designations help us to decide how do we monitor and prophylax patients. In our clinical experience, we've seen a small number of patients with either low or intermediate risk disease go on to develop TLS, which are electrolyte abnormalities that can lead to clinical consequences. So what we did was we put together a consortium of 15 academic and 51 community practice sites, and we asked the question, could we look at additional risk factors for tumor lysis syndrome? We performed univariable and multivariable regression analyses, and what we found was that in addition to the standard risk categorization, the low versus high or low versus intermediate and high, that creatinine clearance with a cut point of less than 80 versus greater than or equal to 80 was an independent predictor of this event. And so what we then went on to do was to calculate the area under the ROC curve for the model that included creatinine clearance and risk, and that was approximately 75%. And then the model which included traditional risk categorization, which was approximately 65%. And the conclusion here is that practitioners should not only account for bulk of disease as measured by nodes and lymphocyte count, but also carefully consider creatinine clearance when modeling TLS risk and also deciding how to monitor and prophylax patients.